Okay, thank you for joining us for the Consortium for Workforce Research in Public Health's fifth webinar series. Today we have two presenters that are going to be sharing with us their research from the first year of this workforce research. I'd like to introduce Dr. Nikki Weiss, who is a researcher in the Center for Public Health Systems at the University of Minnesota. Nikki is a biocultural anthropologist specializing in mixed methods research. Before arriving at UMN, she worked for the Hopkins Center for Indigenous Health, the Great Lakes Hub, as well as the CDC Foundation. And her research interests include health equity and making healthcare accessible and attainable to all. Nikki will be presenting on turnover assessment through integration and harmonization of public health workforce data sets. Our second presenter today is Dr. Casey Balio. Casey is a research assistant professor in the East Tennessee State University Center for Rural Health Research and the Department of Health Services Management and Policy. Her research focuses on the intersection of policy, public health systems, and healthcare, including studies related to governmental public health systems, social determinants of health, and the workforce. Dr. Balio's presentation will be about variation in the public health workforce composition by geography, economic factors, and race and ethnicity. So as a reminder, we have a Q&A set up. So as you have questions, please enter them into the Q&A and we'll get to those after each of the speakers. I'll turn it over now to Dr. Weiss.
Thank you so much for that great introduction. I'll go ahead and share my slides here. And please let me know if you cannot see them for some reason. So first of all, I just want to get started by acknowledging my colleagues on this project. It was certainly not done by just myself alone. So Sky, Suzanne, and Nicole, of course, and JP. So thank you all for your help on this. So today we're going to be talking about the harmonization of public health workforce survey data on employee turnover. And all of you who are here clearly know the importance of employee turnover, specifically in public health. So let's just go ahead and dive right into it. So something that's particularly fascinating to me and something I wanted to use to set the stage, and again, probably not surprising to everybody here on this webinar, is that the public health workforce has declined by almost half from about like 1980 into 2014. So we're talking about 500,000 public health workers to just under 300,000. And if you hear something in the background, that's probably my dog chewing on her bone. So apologies about that. She's very excited about public health workforce. So the next thing I wanted to bring up is roughly like 15 to 20% of the public health workforce left the discipline during the Great Recession. So these specific data points are talking about, before COVID, right? So things are looking pretty dire even before COVID. And of course, even before COVID, my colleague JP did some research and figured out, along with some other colleagues, that we needed an additional 80,000 additional FTEs, so full-time equivalents to provide just basic foundational public health services to the nation. And again, this was before COVID-19 hit, right? So we're talking 80,000 additional FTEs that we would have needed to provide minimal services for public health, right? And then once we get into COVID specific data, so 2020 and beyond, we're seeing that about 44% roughly of governmental public health employees were considering leaving their jobs in the next 5 years. And that could be for various different reasons, but that's a sizable number, right? So all of these things together, our understanding is that we really need to better comprehend public health workforce turnover, and that's critical for us improving recruitment and retention in the discipline. Again, no surprises to anyone who's on this call, but just setting the stage here for our work. So specifically, the team that I was working on, we looked at multiple surveys that collected data on public health workforce turnover. These surveys examine different samples, and so sometimes they present conflicting information, right? Depending on the sample that you are looking at, because by nature, two samples might not be the same, right? And so we kind of ran into complications, and any researcher would run into complications comparing two different data sources. And we're trying basically with this research to compare them and see where they're similar and where they're different. And if they're similar, that gives us a pretty good idea of, that they're reflecting reality. And if they're different, that is interesting too, because we can try to figure out like why those differences might be. So those surveys that we used for this project were, first of all, the Public Health Workforce Interests and Needs Survey. We call this PHWINS for short. I know that this is distributed on an individual level. So for example, it was sent out to individual email addresses of public health workers, and they responded on behalf of themselves. And the other surveys that we looked at were distributed on an agency level, meaning that it was given to one person at an agency and they responded on behalf of that agency. So for example, the National Association of County and City Health Officials, the NACCHO Profile, was agency level. The NACCHO Forces of Change survey was also agency level. And then the Association of State and Territorial Health Officials, or the ASTRO Profile, was also agency level. So we're looking at these 4 surveys and trying to get an idea of, where they overlap, what they're telling us that's reflective of reality, and then maybe also where they're different and seeing if we can come up with any reasons for why they might be different. Let's dive into the methods that we used in particular. And I want to talk about specific definitions of harmonization and triangulation. They're very similar concepts, but they're slightly different. So I do want to just kind of define them before we dive in. So harmonization, the definition that we use was really adjusting data sets to make them comparable. And that allows researchers to aggregate or compare their findings. And I'll also on the next slide kind of walk you through how we used harmonization in our project here. And then triangulation is cross-verifying findings across different data sets, methodologies, or theoretical approaches. And the example that I like to give is cell phone towers. Maybe a bunch of you are having problems with your cell phone. If you are, I think it was AT&T who's out today. But when cell phone towers work, the idea is that eventually you can pinpoint that location by using multiple different towers, right? Same kind of thing with triangulation in sciences, right? So you're looking at multiple different surveys, and where they overlap, we kind of get an idea of reflection of reality, more or less. So our process was that we went through all of these different surveys as codebooks, and we identified themes of the survey items that were particularly interesting to us in terms of recruitment and retention. So those themes might be things like demographics, leave, retire, stay, and hire. And so we settled on those 5 themes, and we basically grouped a survey item into a theme if they matched that theme. So then we would harmonize and standardize similar survey items. And again, I'll walk you through how we do that just in 1 second. So this is an example of the spreadsheet that we created for our data theme spreadsheets. And so let's say that we have 2 different survey items, one from survey A and one from survey B, and they're both asking a similar question about considering leaving. So the first column is just, of course, labels of what it means, and then the next 2 columns would be specifically for the 2 different possible answers they could give for survey A, so yes and no, and then the last 2 columns would be a yes and no response for survey B. Maybe there's slightly different questions in the sense that they're coded differently in one survey to the next. So you might notice within that red box that I've just outlined, the last row in that box, you see that yes is coded as 1 and no is coded as 0. But that's only for survey A. For survey B, it might be that yes is coded as 2 and no is coded as 1. When we're harmonizing, we want to make sure that we're standardizing things as well. So what we would do, for example, and in the next highlighted box there, we've made sure that yes is always 1 and no is always 0. And so we've also given them the same harmonized variable name because maybe they didn't have the same variable name in their original surveys codebooks. So that's kind of what I mean by harmonization and standardization. And then kind of the last part of our process then was to run some descriptive and inferential statistics. And in particular with our inferential statistics, we were interested in a linear probability regression that we'll talk a little bit about in the next couple slides. So I'll go data theme by data theme because we have 5 total, and we'll start with demographics. So the demographics, we have information from ASTO and PHWINS. And both of those surveys showed women make up roughly 3/4 of the workforce in public health specifically. And again, not surprising to anybody probably on this call. The average age of people taking the surveys was about 45, and that was in both surveys. And then average years of service in public health was roughly 10 and 12 years. And again, that was in both. With race and ethnicity, I'm presenting it in this table, and PH wins and ASTO are presented as percent and mean, respectively. And just recall that the way that these surveys were distributed were a little different because PH wins was individual level and ASTO was an agency level. So with these, I've also labeled either with 1 star underrepresented, 2 stars overrepresented, or 3 stars neither under or overrepresented in public health. So for example, white individuals would be underrepresented in public health compared to like the census proportion that they make up. Overrepresented would be Black or African American, for example, or those from 2 or more races. And then Asian, for example, Native or Indigenous would be neither under or overrepresented. So with our next data theme, which is leave, I'm going to break it down into involuntary leave and voluntary leave. So we'll start with involuntary. This was generally pretty low, what we found across the different surveys. So we saw on average per agency, fewer than 1, so 0.29 employees were laid off in 2018. That's NACCHO Profile data. And even fewer than that, 0.14 employees were laid off in 2019, so NACCHO Forces of Change data. If those numbers seem a little bit confusing, another way to think about it is that of the 1,450 agencies who responded to the NACCHO profile, only 107 of them laid off at least 1 employee, like 1 employee or more in 2018. So again, involuntary leave, generally pretty low. Another thing that we noticed was that fewer than 0.1 employees per agency on average saw their hours reduced or were furloughed, and that was in both 2019 and in 2020. So NACCHO profile as well as forces of change data. So that was involuntary leave, but let's also talk about voluntary leave. And that was generally a little bit higher. So we saw that with PH wins, 31% were considering leaving, and that didn't give a time frame. That was just in general. 27% were considering leaving their positions in the next year. And something that told us that employees were leaving faster than they were hired was that 0.79 employees per agency on average were lost through attrition in 2018. And about just about 0.5 employees were lost through attrition in 2019. Now, I had mentioned our linear probability model, and so I wanted to jump back to that. We were interested in seeing if there was any association between identity categories and whether or not someone was considering leaving. So identity categories being like gender, age, etc. Those categories that we saw had statistically significant reduced probability of leaving were people who were Native Hawaiian or Pacific Islander, ages 51 to 60, and ages 61 plus. This more or less makes sense because if you are maybe ages 51 and older, you're not thinking of making a career change. That's generally speaking, right? It could be different for case-by-case basis. And then we didn't have a ton of people who responded as Native Hawaiian or Pacific Islander, so that could be kind of a reflection of sample size. And for those categories, identity categories that we saw had a statistically significant increased odds of leaving, those people would have identified as 2 or more races, they were men or non-binary folks, or ages 21 to 30. And just kind of make things super clear is that the reference groups that we were using for this linear probability model were women, white folks, and ages 41 to 50. And something that I will point out is ages 21 to 30, having that statistically significant increased odds of leaving, again, also kind of makes sense. As a representative of the millennial generation, I can say that there's a lot of job hopping, specifically in my generation, as people kind of narrow down, and especially with COVID, trying to figure out like what they're going to do with the rest of their lives. So again, that is in particular not totally surprising for us. And then also ages 31 to 40. Forgot to add that too. So that was leave, and let's move on to the next data theme, which is retire. So about 20% were considering retiring in the next 5 years, and that's PHWin's data. About 36 have taken steps to retire, and again, that's PHWin's data. And the reason why that might be a little bit higher is you could have someone who's 20 years old who's taken what they consider a step to retire and like creating a 401k, for example, right? We also have the average number per agency who were eligible for retirement increasing from 15 in fiscal year 2019 to 19 in fiscal year 2023, and that's NACCHO Profile data. Similar to that, we have the maximum number of people per agency who would be eligible for retirement. That increased from 51 in the fiscal year 2019 to 61 in fiscal year 2023. So again, what we're seeing is there are a lot of people in the next few years who are going to be eligible for retirement. And that's something that public health is aware of, but it's something that's really going to start affecting our retention in the next couple of years. So let's then move on to the next data theme, which is stay. And this data comes from PHWin's. So as far as primary reasons for staying, and people could select more than one of these, 55% listed job stability as a primary reason for staying. Other top reasons for staying at their jobs included flexibility. So things like flexible hours, being able to work remotely or telework. 48% of people reported that as one of their primary reasons for staying. Job satisfaction was also very high on the list with 43%. Exciting and challenging work at 33%. And then something else that we found that was particularly interesting was about 3/4 of individuals who responded to this question said that the pandemic did not impact their decision to leave or to stay. But of that quarter who said that it did impact their decision, twice as many folks decided to leave public health, or at least their jobs in public health, compared to those who decided to stay because of the pandemic. So again, just want to emphasize that of those who the pandemic was affecting their decisions to leave their jobs, twice as many decided to leave compared to those who decided to stay. And our last data theme then is hire, and this is NACCHO Profile and Forces of Change data. So about 64% of agencies reported that no vacancies had been filled in both 2018 and 2019. About 95% of agencies didn't fill any vacancies due to the lifting of previous hiring freezes in those same years, so 2018 and 2019. About 35% of agencies didn't fill any positions due to employee turnover in 2018, and 41% roughly filled 1 to 4 of those positions in that same year. And similar data for 2019, about 55% of agencies reported that 0 positions were filled in that year due to employee turnover, and another 33% filled 1 to 4 of those positions. So that was a lot of information to just kind of spew at you, but what are some of the main points that I want you to take home? In public health, there are a lot of folks who are considering leaving, and our current vacancies are not being filled. So we have this ongoing difficulty in recruiting qualified candidates. Again, probably unsurprising to a lot of folks who are on this call. And despite the increasing interest we see in public health degrees, for example, especially the public health undergraduate major, we see that governmental public health struggles to recruit graduates. So some thoughts for improvement, because we want to end on a positive note, of course. One thing in particular that could be an area of focus is the long interview, offer, and onboarding process. When I worked at Kentucky Department for Public Health as part of CDC Foundation, being on these interview committees, it would take, a few weeks from the time of the application to get an interview. And then by the time that, a job offer was sent to these folks a couple months after the interview, they possibly had moved on to a different job. They can't necessarily afford to wait 2 or 3 months for a job offer from a governmental public health agency, even though those agencies need to go through all the bureaucratic steps to get that job offer to them, right? And so something else we could focus on is salary and benefits to compete with the private sector. A lot of graduates are moving towards those private sector jobs, and I know that it's tough to compete with them. But state, for example, and feds do have a lot of benefits they could use to entice those graduates. So again, not completely bleak. We have a lot of thoughts for improvement. And with that, I would like to go ahead and end. My email is on the screen if you have any questions. And again, just want to shout out to the rest of my team for helping me with this research.
Thank you, Dr. Weiss. That was very interesting. I do have one question for you, and I'm just watching the Q&A as well. I will share one question in the Q&A is, how did you have access to all of these data sets, and are they publicly available data?
Right. So I think, and I will double check with my advisor, JP, not advisor, colleague. It's something that you do need to have permission to access, but they are available for research for public data. Because some of the journals that we've published and have required these data be public. So of course, like data use agreements have to be in place, but anyone can apply to use them.
Right. And from my experience as a public health systems and services researcher, each of these organizations has a process for requesting their data. And then you have to put a data use agreement in place. If somebody wanted access to the harmonized data, that might be something that we could add into the email that follows this if there's a possibility of using the harmonized data. Another individual asks, does this data only include governmental public health workers, or does it also include nonprofit public health sector individuals?
And again, JP can respond to this, but I believe it's only governmental. So ASTO is like state and territorial, NACCHO is city and county, PH-WINS would be like pretty much everybody, governmental public health. I don't believe that it has any nonprofits. And JP just responded only government.
Yes, yes. Could you repeat how the asterisks are coded for the demographic data? And I'll
Sure.
just pause just a second. Is this already published, Nikki? So can people dig into this in a publication already?
So I believe it actually has been published. It was published. I can find the citation and go ahead and put it in the chat. I think it was just recently published. So I have to I know that we have like the proofs and everything out. I just want to make sure that it's actually available for folks. But yes, I can go ahead. I'll reshare my screen just so that we can go back to those.
Asterisk questions. I was
Yes.
also going to ask, what is the retirement eligible definition? So how do these organizations determine retirement eligible? Is it years of service or is it age or both?
I think that it was different for every single agency. So for example, depending on, you know, if the responses are from state agencies could vary within different states, right? If it's city or county, could also vary like from one county in one state to another county in another state. So a lot of that we're relying on like what has been reported to us from the person who's reporting the data. So it's not necessarily something that is standardized throughout the entire workforce.
Got it. Thank you. So
I realized that I did not hit the rest of that for the asterisk question. So there you go. I apologize for that, but there you are.
great. We're just going to do two more quick questions and then we'll turn it over to Dr. Balio. One person says, can you elaborate on the potential limitations or advantages of agency level, institutional, and non-individual level data versus regular old line level data that everyone is used to?
I think that in general, one of the problems with governmental public health workforce data is we don't do a very good job of collecting it. And so with agency-wide data, you might not be accounting for temporary folks, for contractors. I know that when I worked for CDC Foundation, I was assigned to Kentucky Department for Public Health, but in a lot of their demographic data, I didn't show up because I was a contractor. So that's just kind of a common theme. We've noticed this a lot during our enumeration is that we are, the way that we collect data in governmental public health, we need to do better at that. And a lot of it comes back to funding. And so like we're working with what we can and what we have. So I think that that would be one of the major limitations for that. And was there a second part to your question?
Well, I'm going to switch to another question and ask if you can talk about the strengths and benefits of using a harmonized data set versus a single data source.
Yeah, and I think that for us, one of the big things was for particular years, like for example, when COVID hit, you might not have a ton of responses. And so if you're looking at harmonized data sources, you might be able to kind of look at similar questions in like an off year. So for example, if one of the surveys went out in 2020, but you had another one that came out in 2021, maybe not necessarily representative of everything that was going on in 2020, but like if not a lot of people responded to one survey and they responded more the next year, that would definitely be a benefit. Also in terms of harmonization, allowing us to get both the agency level and the individual level was really beneficial in seeing like if there were massive differences. And we didn't really find anything that was like massively different in terms of, you know, when we're trying to like overlap these data sets and see if there are findings that don't make sense. So to us, that was a way to kind of like verify the findings. If one of the data sets had really stuck out to us compared to the others, we might have wanted to look more closely at like that particular subsample and see like, you know, what was going on there. But they all seem to align fairly well. And that gives us more confidence, I think, in our data.
I would also say that the individuals who are not represented in a workforce survey are those who've already left. And when you have an organizational survey, they're reporting some information
Right.
related to turnover that wouldn't be reflected in a workforce survey of individuals. So that's another benefit of this harmonized data.
Yes,
So
absolutely.
much, Dr. Weiss. I'm going to have a shift to Dr. Balio, and she'll be sharing her slides for us, and we look forward to hearing what you have.
All right. Val, are those slides looking okay on your side?
They look great. You're ready.
Awesome.
Yep.
Okay.
Thank you.
Well, thank you everybody for joining. I think this is the last CWORPH Year 1 webinar, which is exciting. So thank you all for being here, and we're excited to share this work with you. So this work that I'm sharing today is variation in the public health workforce composition by geography, economic factors, race, and ethnicity. I want to acknowledge the research team, which includes myself, Haley Leslie, and Michael Meat. This work was also funded through CDC and HRSA as part of the consortium in the first year, and data was provided by a variety of different organizations, including the de Beaumont Foundation and their PHWINS data, which Nikki just talked about a little bit there as well. For any of those or any of you who are on the call who have participated in PHWINS, thank you so much for doing so. We really appreciate having that data, and I think it is really helpful for learning more about the public health system and workforce. Like Nikki mentioned, there are some limitations to the data that we have available, so having really good responses from PHWINS is extremely helpful for this work and hopefully to strengthen the field in the future. This work is funded and data was supported by these folks on the slide, but they are not responsible for the use or interpretation of the data or the findings in this work. So starting with a little bit of background, many of the people on this call are certainly folks who have or are currently working in local or state or federal governmental public health. For this, we are really focusing on governmental public health, but as many of you know, all local health departments look considerably different from each other. And there's always the sort of age-old phrase of if you've seen one health department, you've seen one health department. And that certainly is the case. And we know that local health departments and state differ in terms of governance structure, the services or activities they provide, their funding levels and sources, their staffing composition, and the local context in terms of policy and demographics and who they're serving. Separate from that, in other areas, there is this sort of known phenomena where having racial and ethnic representation in local government leads to more trust, and this is often referred to as bureaucratic representation. In traditional healthcare settings, we also see a similar similar activity where when individuals sort of match their provider in terms of race and ethnicity or gender identity or other characteristics like that, there tends to be more trust and more openness and better compliance with treatments and other sort of things on that line. So there is this idea that it is important to have a workforce that looks like the people that they are serving in a variety of different ways. From other previous work, we know that the public health workforce is predominantly white, female, and has relatively low levels of formal public health training, as noted through a bachelor's degree or above in a public health program. And there have been significant changes in the workforce composition and pressures during the COVID-19 pandemic, and considerable funding as well, and attention to infrastructure as a result. So because of this, the purpose of this study was really to dive into what the public health workforce looks like across the country, and how well it reflects the organization or the communities that they serve. So our first research question is, how does the public health workforce differ across the country based on characteristics of the community served, including geography, economic status, health resources, measures of need, race, and ethnicity? And for today, we'll really focus on geography, race, and ethnicity. And the second question is, how representative is the public health workforce of the communities they serve in terms of race and ethnicity? For this work, we did a cross-sectional analysis. For today, I'm really going to just focus on the descriptive statistics and the bivariate descriptives by rurality and HHS region. The data sources that we used were the 2021 PHWINS survey, the 2019 NACCHO profiles, and then characteristics about communities from the American Community Survey and Area Health Resources files. Importantly, all of the analyses that you'll see today are at the agency level, but we're using this variety of data that comes from individual level data and agency level data that Nikki shared a little bit about from their study as well. In order to be included in this study, we had a few different inclusion criteria. We required that local health departments were defined by NACCHO as serving only counties or US Census Bureau places, but not a combination of both. And using the number of FTEs from the NACCHO profiles, we had to have at least 10% of the agency responding to PHWINS. That's because a lot of the measures that we're looking at are things like percent of the workforce that is a certain race or ethnicity, or percent of the workforce that has been in public health for a certain number of time. So to get a more reliable estimate of what that percent is, we require that at least 10% of the agency is responding. Our measures of public health specific workforce composition include staffing levels, which are employees per 10,000 population, full-time equivalents per 10,000 population, and then the percent of the workforce that identify as women, that have formal public health training, and that have 6 or more years of in public health practice or 6 or more years in their current agency. And I see a question in the slide. Yes, this is only local public health for this work right now. And then our measures of representativeness are binary indicators or dichotomous indicators of the workforce being at least representative of the communities that they serve for the race and ethnicity groups listed below. So we have Black, American Indian or Alaska Native, Asian, Native Hawaiian or Pacific Islander, BIPOC, which includes all of those listed above, and Hispanic. The other measures that we consider are characteristics of the organization, sort of geographic measures, and measures of the population or community. Agency characteristics include FAB, or the Public Health Accreditation Board accreditation status, governance structure, HHS region, if it's a rural serving health department as defined by NACCHO, and then characteristics of the population are the size of the population served, the percent of families living in poverty, the percent uninsured, if it's a primary care health professional shortage area, and the percent unemployed. So this measure of representativeness that we used is a little bit wonky, so I wanted to dive into this a little bit in more detail. So again, we have these dichotomous indicators of at least representative. As we know, both the workforce and the general population looks very different across the US in different areas, and we wanted to consider sort of scaling this based on the race and ethnicity of the communities that they're serving as well. So this measure is the percent of the workforce, that's that race or ethnicity, minus the percent of the population, that is that race or ethnicity, divided by the percent of the population. So that way it's scaled down to how diverse or how big of a portion of the local community each race or ethnicity group is. And then what we did is we divided this into not representative, which is that lower half down here, and then at least representative, which is that it is sort of greater than the population that they're serving, with a little bit of a margin of error there. And here are two examples. The first one is the workforce is at least representative. In this case, the workforce is 25% Asian and the population is 15% Asian. If you do that calculation, the interpretation is that the workforce is 67% greater Asian representation than the population served. The second example here is the reverse of that, where the workforce is not representative. In this case, the workforce is 20% Asian, the population is 50% Asian, so the workforce is 60% less Asian representation than the population served. All right, on to our results. The first set of tables that I'll show is the sample description. Again, these are all at the agency level, all local health departments. So in total, we ended up with 422 agencies that were included in our sample based on those criteria that I mentioned. And for the most part, those that were serving urban areas, which is the first column of data, were considerably different than those that were serving rural health departments. And then I also have the characteristics for all health departments in the sample. So in general, these agencies were small or medium size. Most frequently, they were FAB accredited. A relatively small share of them were not applying for FAB accreditation. And that is greater in rural areas, which we know from other work previously. In addition, the majority of health departments that are in this sample are either considered by NACCHO as having state governance classification or local. And then here's the distribution by HHS region. The regions that I have bolded here are the ones that had at least 20 local health departments included in the sample. And you'll see that I pull those out later to do a little bit of further analysis on. And then in general, we see that rural serving health departments tend to have higher poverty rates and lower education levels than the urban serving counterparts. And now to dive into the workforce characteristics. Each of these graphs will go from urban on the far left, then to rural, and then to combined, and these are averages. So on average, we'll start over here with employees per 10,000 population. Of all of the health departments in our sample, they had an average of 5.6 employees per 10,000 population. This was higher in rural serving health departments at 6.7 per 10,000 than urban, which was 4.6 per 10,000. Similarly, FTEs per 10,000 population were higher in rural. We see that there is a greater percent of the workforce that identify as women in rural. There is a lower percent of the workforce with formal public health training in rural. And then there is no significant differences in terms of these two measures of tenure in rural and urban. In total, or of all the agencies included in our analysis, about 67% of the workforce has been in public health practice for at least 6 years, and about 57% have been in the same agency for at least 6 years. And then these are those HHS regions that had those larger sample sizes. And these are intended to show that there's some pretty considerable variation here at the region level. Ideally, we'd like to get down to the state level or even more local than that in the future. But from the limitations to this data and sample sizes, we have kept these at the HHS region level. In general, we see some pretty wide variation here across the regions. Region 4 tends to have the highest staffing levels and among the longest tenure. But has the lowest percent workforce with formal training in public health. Region 1 has the highest among, again, among those agencies that are included in our sample here. And then diving into the racial and ethnic representation, these figures look very similar, but these, instead of averages, are the percent of agencies in our sample that are at least representative of the population served for each of these race and ethnicity groups. So starting with Black or African American on the far left here, of the agencies in our sample, 33% were at least representative of the Black or African American communities that they serve. 44% of those in urban areas were at least representative compared to 21% in rural, and that was a significant difference. We see a similar pattern for all of the other race and ethnicity groups here, where urban has higher representation than rural for all groups except for Native Hawaiian or Pacific Islander. And then here are the same figures done by region again. In general, regions 4 and 5 tend to have the highest level of representation, again, among the relatively small sample that we have here. But we see some big differences here. When you combine all non-white and BIPOC groups together, the highest is in region 4, where 86% of the health departments in our sample were at least representative of sort of the BIPOC population. And then for Hispanic, this is the lowest we see is in region 1, where only 30% of agencies are at least representative of the Hispanic population that they serve. So there are some important limitations to this work. First, we have about 420 health departments in the analysis, which is a relatively small number of all health departments. And this is a function of data limitations that we have. The sample that we have has slightly greater FTEs per 10,000 population than all local health departments. It's slightly greater percent that identify as women, lower percent formal public health training, and slightly greater tenure within their agency than a national sample. Again, there are response biases in both the NACCHO profile data and PH-WINS. And PH-WINS is not designed to be representative necessarily at the agency level. And like I mentioned early on, we used that 10% threshold for the number of individuals that had to respond. So we are sort of at the whim of any response biases that may exist within that data. And then lastly, this is correlational only. None of this can be interpreted causally. So I think there are a few important takeaways from this work. First, we've always known that there's variation in workforce composition across the country, but this really dives into a little bit more detail in terms of how and where that variation exists. The important next step to this work is to understand better what the impacts are of these variations and how we can understand how to improve the workforce moving forward. This is a novel assessment of representativeness within the public health workforce. We do find some promising levels of representation in terms of race and ethnicity, but there's certainly room to improve, and this varies again across the country. There's lots of ongoing work in the field by others in CWORPH, as well as many people on the call and in practice around recruiting, retaining, and succession planning in order to really facilitate a strong public health workforce. And then lastly, we again have seen significant changes and increased attention and funding for public health infrastructure, including, that should say, the public health infrastructure grants from CDC and other funding that has come out in recent years. Here's my contact information. This work has been submitted to journals but is not publicly available yet, but we are happy to share that with folks once it is available moving forward. So thank you everybody for being here and for joining all of these CWORPH webinars.
Thank you so much, Casey. There are a number of questions in the chat. A couple are methodological questions that you might be able to just briefly touch on for folks. Why is tenure at 6 years? How did you define rural, and how do you define formal public health training?
Yes, so tenure is 6 years because that is how PH-WINS asks it. They do it in buckets, so it's 0 to 5 years, and then 6 to 10, I think 11 to 15, and then 16 and above. So we used 6 and above for the threshold here, but we could certainly play with that and use a different cutoff there as well. For defining rural, this is how the NACCHO profiles have defined it. And I know JP is actually on this call, who I think was involved in really defining that. They have used different ways to define rural over time. JP, if you want to throw in the chat, if you're still there, I believe it's a combination of what proportion of the population served by the local health department is considered rural, but I will let JP jump in there. if there's anything different. And then formal public health
You're
training.
correct.
Oh, great. And then formal public health training is a bachelor's, master's, or doctoral degree in an accredited program or school of public health.
Related to that, the formal public health degree, there's a very interesting question that I think would be nice for discussion. With so many investments being made by departments of health on job training and professional development, has any effort been made to capture the level of public health knowledge acquired on the job? The reference for formal public health in many studies still places a higher emphasis on formal education, which has inequitable access.
I agree. That is absolutely something that is a limitation to this work and the way that we identify this. One of the reasons that we wanted to include the tenure was really trying to capture that institutional knowledge that folks have that have been in public health, either practice or their current agency for a long period of time, and may arguably be sort of stronger training in public health than one would receive in a formal degree program in public health. We also know that there are lots of other trainings and lots of other fields where there are important skills that folks learn that are applicable to public health, but may not be in formal public health schools or programs. I don't know if there have been efforts to capture that or measure that in other ways. If anybody else on the call has any ideas, feel free to throw them out there. Val, I don't know if you have any,
Yeah,
if you
I
know
have
others doing that work.
some thoughts. I very much, I think those of us doing workforce research really appreciate this concept, that formal public health education is somehow superior than experiential expertise. And we do other things to assess expertise. So the gaps and competencies assessments and PH wins give us a sense of workforce experience and needs. We also have CPH as a mechanism for vetting expertise, the Certified in Public Health exam, which there are lots of opinions about the exam. I know it has a cost, it has a renewal process, but we do track that through PH wins as well. So we can look at expertise and competencies using the PH wins data, not just formal public health training. And I don't off the top of my head know what the research says on do these things align with one another, fewer competencies in CPH or more gaps without public health training. We've written a number of those papers, but off the top of my head, I don't know the findings. And I do see there's another comment in here. I'm going to just check. Nikki suggests that there's a push for health departments to fund advanced public health degrees of their employees in order to provide incentives for them to stay. And I have seen that in the state that I live in as well. But I think it's a nice conversation for us to continue dialogue around. So thank you for that question. There's one more question for you, Casey, which is, are there plans to compare this representation data with actual health outcomes? I think you alluded to it very briefly at the end, but could you speak a little bit to that?
Absolutely. I think that is what we would like to do next. The only caveat to that is we can look at sort of associations with health outcomes, but because of how this data is structured, it's going to be very challenging to do that sort of causal step of does having a more representative workforce actually result in better health outcomes. I think we would love to do that. And if anybody has sort of ideas of how that can be done, we would be all ears. I do think there may be some opportunities to really dive into this in more detail as a result of the FIG funding and other changes in staffing that have happened during the COVID-19 pandemic. And there could be opportunities to sort of leverage changes in staffing to look at what those outcomes might be. Great question. Definitely something we would like to do in the future.
There are two other comments and questions. Could the presenters comment on the question of representativeness and diversity within the public health workforce? The first presenter seemed to suggest that Black and Hispanic populations were perhaps overrepresented, but the second presenter suggested there's more work to do to achieve representation. Could you guys reflect on each other's results?
Absolutely. So Nikki, feel free to jump in here as well. Nikki, I think yours was done compared to the census totals. Is that right? For the US totals. So ours is reflective of the local level. So it's actually looking at the agency and the geography that they serve. So it's a little bit more specific. However, we have a much more limited sample. So again, we only have about 420 local health departments that are included in this. So I think part of that is sort of the national level versus the local agreement or concordance or representation, depending on how you want to frame it.
Yeah, I think a lot of it does come back to representation, especially when we're talking about which surveys were done like right after COVID, because there just wasn't capacity for folks to be responding to surveys when everything else needed to be triaged. Then responding to surveys basically went to the bottom of the list, and so that certainly could have affected like which agencies tended to respond more, or et cetera, et cetera. So I think definitely representativeness plays into that. And I think it's also something that's just like an open research question too, that we need to dive into more. Health equity in terms of especially like makeup of the public health workforce is always something that we need to work on. And that includes just getting more data about it so that we can better understand it.
Thank you both. There's one more comment in the Q&A that I'd like to just briefly discuss. An individual suggests that as a person with a PhD in biological anthropology, I find it very difficult to get people to understand the relevance of my degree and experience to public health. And I have a confession that as an academic, I have been swayed to think that a formal public health degree is really essential to governmental public health work historically. Last year, having conducted a workforce assessment and then sat through 50 plus interviews with division directors in my state, I really began to understand how varied public health work can be, especially in state governmental agencies. And someone who's, for example, handling weights and measures and scales that measure things in the state may not have the need to apply a formal public health degree to their day-to-day work. So while I do believe much of the work that is being done in governmental public health agencies can benefit from a basic introduction to formal public health, not every position needs that. And it is something that we need to keep in mind as we are drawing conclusions from our assessments using these data. So I appreciate the perspective of the attendee, and I recognize that I'm sharing my own personal opinion, but there are others who may have differing opinions. There are people who've been working in the workforce for a long time. To Casey's intention to represent that through tenure, a lot of learning can take place on the job and can be very highly valuable and meaningful to an individual's application of that work. So I think it's an ongoing conversation. It's an ongoing question that we need to continue to explore what the value of formal public health is, and if it's more valuable to specific positions within governmental public health, we should start talking about that.
And to jump on to that, because as someone also with a PhD in biological anthropology who struggled with jumping over, I think that it took me a solid year of AmeriCorps service. So when I first got my PhD, it was in the middle of the pandemic, like April 2020. There weren't jobs for biological anthropologists, right? And so it was a lot of learning how to market my skills as a biological anthropologist to public health. And it took a lot of time. It's something that I don't think that anthropologists are very good at. So we also have to not only train public health in terms of like rewiring our brains to open up to different backgrounds who don't necessarily have formal training in public health, but we also need to train people how to market themselves for public health jobs too. So feel free to reach out, anonymous attendee, like if you want to discuss that further, and I'll pass it back to Valerie because I know she has a call for this.
Yeah, we have one more slide that we'd like to cover before we say goodbye to everyone in just a couple minutes. There's lots of words on the screen, but I'll just start by saying if you're conducting work related to public health systems and services research, there is an open call for abstract submissions to the Academy Health Annual Research Meeting, which will take place this June in Baltimore. We have an interest group focused on PHSSR. You've probably seen some attention to this topic with the Academy Health recent release of the new PHSSR research agenda. But we are looking for abstract submissions. If you've never attended this meeting, you can submit. You will need to register to attend this meeting if you haven't accepted abstract for the meeting. But we're looking for interesting research in this area. I will add the submission link in the email that goes out with the recording from today's webinar. Thank you all so much for joining. I know there were one or two questions in the Q&A we didn't get to, but I'd love to continue this dialogue as we move forward. Thanks again. Have a nice afternoon.